Yes, I'm David Joske, haematologist here at Charlie's, part of the woodwork these days and about to retire. So I trained locally. My father was Dean of the medical school when I went through, and so I was a bit of a marked man really, and I had to make sure that I didn't besmirch the family name, made sure I passed every year. Then I did my intern resident years. I took a gap year, which included 6 months working as a house officer in Edinburgh, and then I did 3 months on an expedition in the Amazon, and they put me in charge of a group of people, and we were building a school and stuff like that. And that time away convinced me that I didn't want to do emergency medicine, which I've been thinking about. So I came back and studied for my physicians at Royal Perth, in the old Royal Perth. Having passed that, actually fell into a bit of a hole because I hadn't thought about anything beyond that exam, and eventually decided to do haematology because it was such an interesting body of knowledge. And then I swapped over to train here from Royal Perth, which a lot of people were aghast at the time, and did most of my haematology training here. I finished it overseas. I teed up a research position in Lausanne in Switzerland on a UWA scholarship looking at virus gene expression in Hodgkin lymphoma. Then I did a couple of clinical years at the Royal Postgraduate Medical School at the Hammersmith Hospital. And that brings us to August 1994. And at that point, they wanted me to stay in London. I was actually on my way to a job in Melbourne. I was a transplant fellow. I decided to do a brief locum here, and the former colleague decided to retire, and I was appointed as a green consultant and as head of department. And the reason I took the job here is because the London job would have been great, the Melbourne job would have been great. I would have loved to have done some time over east, but they were both the means to an end, whereas the job here was a greenfield chance to build up an academic department of haematology, really from nothing. And so I set myself to do that. Since I've been here, of course, I've appointed a lot of people into positions, and as consultants, we all know how hard it is when you're starting as a consultant and you first have to make those decisions and take those responsibilities yourself. Whereas a registrar, you've always got a consultant to do the worrying. And I look back now and think, I don't know how I balanced learning my trade as a consultant plus being a head of department and being thrown into hospital politics, very green. And at that stage I was head of clinical and laboratory haematology here, and it was a tough time. It was a tough 5 years at the start, but actually a pretty supportive environment in the hospital generally, and things started to come into place. I got sidetracked from my 10-year plan, went onto the hospital executive committee for 5 years in the late 90s. That delayed some of my plans a bit. And then in the early 2000s, I started Solaris Care. That delayed some of my plans a bit. So what was a 10-year plan blew out to about 15, maybe even 20 years. And I set myself to get clinical trials happening here. There were none. And to get some basic research going as well. I can remember having a conversation with one of the ALLG executives, Janie Stone. It must have been about 98, and I've been here 4 years. And she was saying, I don't understand why you're not more interested in trials. And at that stage, I'd been able to get 4 up and running, or something like that. And she just didn't understand what the difficulties are and the barriers are that exist to clinical trials. It takes a long time to build up a head of steam where the trials are generating enough research monies that you can do more trials, and then you get into the positive feedback cycle. It took a long time to really get ahead and get the trials happening. And then gradually, by and by, Charlie's became one of the major contributors to a lot of the ALLG trials. I think fortunately that the culture is through the department. Everyone believes in research. And in some ways, Chan electing to come here is a positive outcome from those years of building up research and creating an environment where somebody as good as Chan can come and just take it up to a whole new level, as he's done. I think in broad terms we've changed a lot from randomized trials comparing A versus B whether it's standard of care plus a new agent versus standard of care plus a placebo, or just new agent versus old standard of care. And we're really getting now into, particularly here with the success of the WA Blood Cancer Research Centre, a lot more first-in-man studies, a lot more observational studies where we're just going straight to the new agent and seeing how it goes. The complexity has definitely increased, and that's in part because all of the benefits of the molecular biology revolution are bringing in a host of new therapeutics, and we actually need, I think, as a scientific community, to find ways to quickly identify the new drugs that work and get them into the bedside. One of the things that I think was a great shame in Australian haematology was how long it took rituximab to go from first being cautiously introduced in clinical trials in the early 2000s, or about 1999 or so, to getting onto the PBS took about 10 years. And that's way too long, and it meant that a lot of patients who would have benefited from it weren't getting access to it. So I think we've seen the field of drug development and trial protocols speed up, thankfully, and that's a really good development that patients will benefit from. I was talking to a patient today who I was telling her, look, she may well be suitable for a clinical trial when her low-grade blood disorder, blood cancer, needs treatment. And so she asked me, so is this compared to placebo? And I had to say what I've just said to you, which is that these days a lot of the trials we go straight to the therapeutic agent. We don't have a control arm, or we use historical controls, which means that we can introduce these drugs much more rapidly. But it does bring a host of statistical problems in terms of arriving at proof of efficacy. That is an issue we're going to have to grapple with. So in my professional lifetime, I've really seen 3 blood cancers change incredibly, in fact. The most impressive really is chronic myeloid leukemia. I have a photo on my slide set of a lady called Catherine, and one of my prouder moments, she was the first person in Western Australia treated with imatinib, the new designer drug for CML, in 1999 as part of the pivotal IRIS clinical trial. And really, we've seen CML go from a disorder where a lot of patients had to have an allogeneic transplant with a 10 to 20% mortality to really just 4 tablets a day and the leukemia melts away. And now we've seen second and third generation versions of imatinib. And we've got to the point where CML, which was one of the most transplanted forms of leukemia, really now is associated with a normal lifespan and a normal quality of life. Incredible change. And sometimes it's hard to get CML patients to take the medication, and this is one occasion where it's good to be a bit longer in the tooth as a haematologist, because I can say to the patients, I can remember when we had to do transplants for this and people died. Take your medicine. I think the second disease has been non-Hodgkin's lymphoma. The introduction of rituximab lifted the cure rate in diffuse large cell lymphoma by a significant 15%, from 45 to about 60%. We've still got a long way to go with that disease, and there's a whole raft of new therapeutics, and we're going to have to work out how and when to introduce them into the patient's treatment, whether we start to do it first line. That's what we need clinical trials for. And then the third disease is multiple myeloma, which in my professional lifetime, the average lifespan, although we still can't cure it, has picked up from about 3 years to now approaching something like 8 or even 9 years. And I have more and more patients under my care getting out to 10 years and 1 or 2 even to 20 years since their myeloma was diagnosed. And the great thing about these developments are that they're not traditional blunt chemotherapy. The new therapeutics, the targeted drugs designer drugs against particular molecules or pathways, because they're not chemo, they don't have all the friendly fire side effects on the other dividing cells in the normal body. And so they're much more patient friendly, and it's been fantastic to see treatments evolve towards oral at-home therapies with less side effects, less risks, and it's going to be fantastic, in fact, to see the next 10 years and see what happens. So I guess inevitably as you retire, you start to think about legacy. In fact, as I've gotten closer to retirement, I think about it less because I'm kind of looking forward more and more to the next bit. But I can say that I have as a legacy, I've had a fair hand in developing a good department of haematology here and in Solaris Care. And yes, I'm very proud of the clinical performance of the department and the involvement in clinical trials. But in some ways, I'm most proud of the kind of physician self-care that we've managed to build in the department. We have great confidence amongst the colleagues that we will look out for each other. If we spot somebody's in a bit of trouble with clinical overload, we'll immediately step in and take them off call for a while until they get things back under control. And so this kind of pastoral element to the department, I think, is not that common, sadly, and I'm very proud of that. With Solaris, I think it's a fantastic story that all Western Australia should be proud of, actually. We've now treated something like 25,000 plus people through Solaris and complementary therapies just to help them get through the cancer journey with less symptoms and with less side effects from treatment, or managing it better, or empowered to manage it better. I do feel like we still miss the boat on good survivorship care in Western Australia. That is after cancer care. That's a whole different story, perhaps. I would probably say my proudest moment professionally was giving the Calder Grucci oration at the 2019 National Conference. That's a great privilege to give that talk. I'd like to think I did it justice. To be able to speak as a wise man amongst the elders of your profession is a great privilege. So I've been telling people that I'm not retiring. I'm going to have a second career in music. I've loved playing music for a long time, and in fact, strange enough, it was a patient or a patient's mother that gave me permission to follow music. Way back when I was a green consultant in 1997, I was looking after a young man with acute myeloid leukemia, and it wasn't going well. We weren't winning, and his mum was on the ward every day, and it was getting harder and harder to face up to where things were headed. And as it happened, the band that I was in at the time had a regular gig on a Wednesday night, and we played that night. And some of the nurses in the ward came along, and there was this patient of mine's mum. And I felt awful, here I was up on stage enjoying myself, and this dire situation with her son back at the ward. And the next day on the ward round, she said to me, "Thank you so much for the music last night. It really gave me a chance to forget how things were and to just relax and have a bit of a good time for a while." And it made me realise that it was the same for me, that music was a form of therapy. And she kind of gave me permission, and I decided from that moment that whenever I'm on stage, that's musical me, that's separate from anything else I might be doing. With retirement, I'm planning to concentrate on music, and I kind of decided after a conversation with a mate that if I retire to me time, it won't work. I've, like many doctors, it's been a lifetime of service, and I don't really want to stop that. So I'm going to try and make music my way of serving people. I'm not a great musician, but when we play, it does bring joy to people, and so I'm going to change what I'm doing in retirement, but not why I'm doing it. And that fits much more comfortably with me and help me make the decision, in fact. But I have very, very mixed and strong emotions both ways. On the one hand, there's a lot of people I've known a long time, colleagues and patients, that I'll miss very much. On the other hand, I won't miss the bureaucracy and the form filling and the mess that is the car park here, but it's the right time for me, and there's some great young people ready to come through. As the WA Blood Cancer Research Centre has articulated very well, clinical trials mean hope, and they mean hope for an individual patient, but in a collective sense they mean hope that we'll achieve much more patient-friendly cancer treatments with higher cure rates than the old treatments we were giving before. And the only way to get there is with good science done through good clinical trials. So they're essential, and I am very proud that in this hospital and with Linear and with WABCR, we're really in a strong position to contribute at an international level to advancing how we treat blood cancers. It's a fantastic thing.